him and me and some discussions among ourselves and others that this might be helpful to throw something like, bring folks up to speed in terms of where the is as it has relevance to this new proposal. Is there is something happening on the line?
Yeah, let me just ask if folks could mute your lines. We do have the telephone audio lines open right now, so any background noise we can hear. So if folks would mind muting your line as Betty steps us through the presentation, then you can unmute as you have questions to ask, and that'll probably help with the sound quality a little bit.
Okay, so jumping in here, and my apologies that there's a very large purple square on the slides. I'm not sure how that happened, but anyway, the Husky University of Washington purple kind of got a little crazy there. But anyway, hopefully you can. This text for this presentation today is we only have an hour. It's a little hard to hear. I think somebody might their telephone too close, something like that, or eating in the telephone or breathing heavy. So please mute your line. But what we were going to talk about today was not do a lot of background to FAST, so hopefully be familiar with FAST, but really talk about right now in terms of where we are to date, types of data we have in hand right now, what resources and platform currently exist through FAST, and I'll talk a little bit about what that means. And then we'll really launch into the last half of this 1-hour webinar to talk about how we might be able to leverage FAST for future research. But that's really a discussion for all of us to have together and with Glenn and I and others. So moving ahead, just very briefly, to bring everybody back to the same place about what is this FAST public health activities and services tracking study or collaborative or initiative all about. The purpose essentially is to ultimately establish kind of a data repository for comparing the effectiveness of local public health services and having sort of a central place for data around that we can look at over time, people can access for different studies, et cetera. And ultimately then provide evidence for public health programs and characteristics most effective in improving population health, and I like to point out too, more effectively reducing health disparities. I won't go into a lot of the detail around that background, but you also got a handout by email that gets into that a little more broadly and gives a little more description in terms of the background. But ultimately, in the parlance of comparative effectiveness research, it's looking at sort of what works for what populations and under what conditions. Now, also in the context of variation, as Glenn described, we're also looking at, in part, to examine and address unnecessary variation in local health department practice, because we know through previous research that there's tremendous variation and that it is a bad thing, unnecessary variation, over-variation. Also, we have this rather unfortunate opportunity for natural experiments in which we can expect that we'll be able to see and show that some of our services as they're being cut, are really impacting vulnerable populations in particular, and thereby we could show particularly some of how health departments contribute to population health. So this is how I want to talk about this briefly today, is in these quadrants sort of activity, and we've been conceptualizing this way, and we have data and information on all those headings and subheadings, but I'm going to kind of highlight areas out of those 4 quadrants. And a lot of this work in sort of organizing how we look at this and what we're doing is being done with a tremendous help of Greg Whitman, who's right here in this room with me. Greg, say hi.
Hello.
And Greg's going to talk a little bit more about the data management piece, et cetera. So he's been tremendous in helping us pull this together. So don't worry, I'm not going to talk about all this information that you see in these quadrants. But first, let's talk about the collaboration piece. In terms of collaboration piece, this really is a truly collaborative effort. A big part of this is working through and with public health practice, and many of you know this because I've been on the phone with many of you and behind the scenes with many. And right now with FAST, we have data, retrospective data from 10 of the 12 PBRNs. We've talked to all the people represented from all the PBRNs. We've been cleaning data so far from 4 states in particular. Not that we're ignoring or necessarily neglecting the other ones, but it takes time, and we've kind of been focusing in on certain areas. So, in working through with 4 states and with some additional new research funding that we'll be able to use to sort of dig in a couple more states and having additional discussions about. So as we get additional research, we dig deeper into some of these other areas and with more of the PBRN states and some of the data we have. We also have this really fabulous collaboration with across schools here at the University of Washington in particular, but also with Glenn and them at University of Kentucky, with folks at University of Arkansas and elsewhere. But here at the University of Washington, of note is this Greg's and my new best friends here at the University of Washington are at the Center for Studies in Demography and Ecology. I just point out them in particular because they've been tremendous experts in helping us develop a really comprehensive, well-designed, expandable database, relational database, as well as having a tremendous amount of experience at GIS, at mapping, at linking, geographic spaces. As you know, many of our local health jurisdictions count county level data. They have a lot of experience in helping with that, and they've also got expertise in analytics, which is a whole another area that a lot of us have less background in. So they've been tremendous, and that's a resource that is brought to bear here. Hopefully you can see this. This next slide is really just touching upon again that collaboration piece. Looking at these concentric circles kind of show how we sort of are conceptualizing our team structures. We've got the main sort of key people that those of us that are doing this all the time, the sort of key staff and other PIs and that have been integrally involved in the research and then of course all of our PBRN state representatives that have been very involved with us. And ultimately, we don't have this yet, but we'd like to formalize before too long sort of external advisory committee to this. But at the time, right now, we don't want to sort of impose more structure than is necessary, but we'd like to get there. So moving on to another quadrant, and that is around this data piece. Really what we've been looking at to date so far has been in this retrospective, or among retrospective data. Now, at the end we're going to be talking, the latter half of this webinar, we'll talk more about the prospective data that can happen with this additional grant funding. But first, to give us a little grounding of where we are with retrospective data, we asked these questions initially to try to find out where to start, what data exists, et cetera, and really trying to get data that are different from the nature profile. We don't in any way want to duplicate what's on the nature profile. So we're doing a lot of sniffing around out there to see what else was available, how far back the data go, how accessible are they, et cetera. The type of data we asked for in particular were around these local health department services. So we were pretty quickly finding out that data tended to be more consistent, more available around these three areas: maternal child health, environmental health, and communicable disease control. We were looking for data that were provided directly by health departments just at this time, just to make it sort of easier to get at some consistency across data. And looking at this time frame, we found that there were data that were kind of commonly going back as far as 2005 or more, but we thought if we could capture 2005 going forward, we'd be able to also capture that natural experiment piece where the budgets, the financial crises really were occurring. The source, we're really looking at data at the county level or the local health department level in particular. We're retrieving them, getting them from the state, at the state level, not bothering all the individual health departments. And we've been getting data. First, we were really looking at service data, amount of service delivered, that kind of thing, but we're also finding that there's a pretty fair amount of pretty detailed expenditure data with expenditures, dollar expenditures per service area, which has been pretty interesting. Now, I just show this model here as an example to look at, to get a sense of what's in our data set currently. So this model we're using for how we're thinking through some of our M.P.H data right now. We're just starting to analyze a data set, a good-sized data set we've got with regard to maternal child health services. And in putting that data set together, and in our initial analysis, we looked at, okay, how are all these pieces going to fit together? So that's sort of a theoretical model we've got there. Oops. My circle.
Oh, it doesn't work.
Wait. Hang on. I'm stuck. Can someone, Glenn or Ann, could you advance it to slide 10?
Did that do it for you, Betty?
Can't advance the slide.
Oh, hang on. You want slide 10?
Yeah.
Is that the right slide?
Don't seem able to advance the slide at the moment.
I just took that power away from you, but I'll give it back to you, Betty.
Glenn.
Sorry.
Okay,
try it now.
Cannot. Well, you can keep the power, Glenn.
Okay. All right.
But what I was going to show you, we have nifty little circles and squares on that model, which don't seem to be appearing. But if you could go back to 10, Glenn. The nifty little circles cover the three pieces in the middle there: total local health department expenditure, M.P.H expenditure, and M.P.H services. And those are all data that we've gotten directly from our PBRN partners, and comparing them across a handful of states in this initial database, and making them comparable and workable. And we've got data over time for 5 years, et cetera, in those three domains there. And then the squares, there's nifty little squares that go around LHD characteristics and non-LHD M.P.H services in that jurisdiction. And those two come from our data pieces that we've drawn from the nature profile. The others are things that come out of national data sets, et cetera. So we've got those as an example. This is the kind of data that we're pulling together and linking geographically, et cetera, in relationship to county, or not just county, but local health department jurisdictions and county level related data. Okay, so that's just an example to give you a sense of what's in our database. Slide 11, Glenn. We're going to talk a little bit about what's in our inventory. These are data, retrospective data that we've gotten from individual state PBRNs, and here's an example we're going to highlight some of those data, and we're going to focus here on communicable disease control and environmental health, because this upcoming grant opportunity focuses on communicable disease control, environmental health, and chronic disease. Now, I can tell you we didn't actually ask for chronic disease data yet at this time, and that was purposeful because we figured and we understood chronic disease data to be less consistent and more squirrely, and we thought, well, let's do with the less squirrely stuff first. And so we appreciate that this new grant opportunity will help all of us kind of get our heads together around collecting some of this harder to quantify or understand data, particularly around chronic disease. But let's look at what we have in terms of communicable disease. So from a variety of states, and we've got them depicted there, we've got immunization data that show different kinds of ways of looking at vaccines given, TB reported and investigated cases. So if we have TB data, if we have communicable disease data, we were really asking people for communicable disease data that indicate a local health department providing a certain type of service, and in this case, investigating communicable disease, not just number of cases reported to the state or at the state level, because you know, a community physician could have done that, but these are cases investigated by the health department. So we have that for TB, we have that for STIs, and we have other communicable disease control data there as well. And you see just a sort of snapshot here. Now, these are actual service data. We also have expenditure data, detailed expenditure data for a few states, too, around how much a health department, each health department spent around, certainly around STDs and a few other areas of communicable disease control per year per local health department in some of these areas. Next slide, Glenn. So here's an example of environmental health. We actually have a fair amount of restaurant inspection data that's pretty interesting. And we know from our buddies at in the Center for Demography that they also have data around number of local retail food establishments per county per year. And they have those located, et cetera. So there'll be some interesting opportunities there. Other kinds of inspections we have data for. We also have permitting, on-site sewage, that kind of thing. And we have Connecticut water, Connecticut and Washington there, and we forgot Ohio, right, Greg? Ohio is also one of those. Well, we have some. We forgot to show some data for Ohio.
Right, that was foodborne
illness
investigations and waterborne disease by county.
Okay, that would have gone on the previous slide then. Okay. So next slide, Glenn. And I'm going to have to step it up here. So the data management. You want to say briefly about data management, Greg?
Sure. So this is things that we have just applied general data management principles to this specific data. One of the really important things that we need to be able to do is whenever we're looking at, you know, our final clean data, to be able to identify the source. You know, you can look at some numbers and say, okay, where did you get that? That's really what is very important to document that. One thing that really helped us for today's presentation and for a lot of other just queries about what information do we have, what data have we collected, is an inventory database, and right now it contains a record for each data file that we have, and we have original files, and then we've made modifications, and we keep track of all of those. And when you have a study that involves this much data that comes from so many different sources, you really can't survive without an inventory database. And of course, data dictionaries, you need to know what those numbers actually represent, and a lot of the information that we get from the states comes with column headers that are cryptic and just sort of numbers and letters, so we really need also to know what those actually match up with. Another thing that we decided to do is pretty much just string everything together, and the way we're doing it is using the web. It's actually a wiki, so that's one way that we can tell which original data connects with a modified data set, and also help us keep track of all the modifications that were made. It helps to link any correspondence, any of the sort of email conversations that we've had in order to obtain the data, actually link that with the data sets. So anyone who comes and looks at our final data set, or even is reading a paper that describes, you know, the analysis, could come and look at this wiki and trace their way back from the final to the original.
And next slide, Glenn. Or people who ultimately then would download some of our data and use it for your research. Exactly.
Okay, so of course quality control is an important part of data management, and these are the three areas that I've identified as most important for what we're doing. Data verification, of course, which can be sort of tricky when you're relying a lot of times on just one source of the data. So what we have been able to do is some of the data actually appears from more than one source, so we can compare those to see if there are any mismatches. And we've been able to do that and find out what's the real actual number supposed to be. And of course, you can look time-wise is the most common way that we've been able to look from year to year, and if we see number of WIC clients served dropped by 50% from one year to the next, then we have to find out, is that real, or was there a data entry error or some other sort of error worked its way into the data that we started with. Completeness, one example that applies to what we're doing is we get a Excel spreadsheet that's got a bunch of local health departments listed in the first column, and then a bunch of data goes across the sheet. We need to make sure that the list of local health departments is complete, and there have been a couple of occasions where we didn't catch that fact until later. So now we have a master list, actually, of all of the local health departments. So whenever we get any new data, or when we start to examine data, we first will check to make sure we have all the LHD's data for each one, and if we don't, then we can go back to where we got the original data to try to get that. We also, in these spreadsheets that we get, sometimes there are blanks, so we need to go and find out, are those missing data, or is it zero? Again, say WIC clients served mean no WIC clients were served by that LHD. And finally, spot checks. Anytime that we've taken data from one place to another, from a PDF file to a spreadsheet, or from one spreadsheet to another, we need to check it just to make sure all the mechanics of moving data from one place to another went properly.
And that's proven fruitful many times.
Yes.
So, okay, Glenn, the next slide. So the data management piece has been pretty huge, and the deeper we've gotten into this, the bigger and messier it gets, and we've pretty quickly found out we needed to have a very, very well-developed sort of system of managing these data. So just to talk briefly then about this quadrant of research, we have some preliminary studies underway. One we're publishing right now in MMWR with about WIC, and we looked at Washington, Colorado, and Florida. Another one I sort of briefly touched on about maternal child health expenditures, so we started with Washington, Florida. We hope to soon know whether or not we'll be doing a study on maternal child health, environmental health, and communicable disease control expenditures and outcomes, and that would be looking at these 4 states. And then we're always sort of contemplating future studies, which I'll touch on just as we're finishing up here. So next slide. So just quickly, the findings from some of these is regarding WIC. We looked at starting out with kind of a, quote, simple question. How does WIC service provided by local health departments vary and change over time? And we sort of started with this to see how doable all of this would be in terms of linking all these data over together, and found a lot of interesting differences across the states, but we really focused on looking at the states as a whole, or looking at all these local health departments, and found a lot of difference around urban versus rural activities going on. Local health departments increasingly providing more WIC service over time than Medicaid need would suggest. So the amount of service they were providing went up faster than as the need, quote, need was going up. And in particular, this was happening far faster in urban areas than in rural areas, suggesting that urban areas are having quite a bit more success in this economies of scale, perhaps. Next slide, Glenn. Regarding maternal child health, we looked at, or we're looking at right now, are maternal child health related expenditures by local health jurisdictions predicted by need. And then ultimately, of course, we want to look at that in relationship to health outcomes. But so far, we're just doing some descriptive work, which even of itself has been pretty interesting, that and finding that maternal child health expenditures are really decreasing as a % of total local health department expenditures, and even as the number of Medicaid-funded births in that same jurisdiction are increasing. So, of course, there's a lot more we could say and look at in there, but that's some initial findings. And that rural local health department MCH spending is much higher than urban areas when examined per Medicaid births. It's much higher in MCH, or it's more costly for those local health departments in rural areas. So next slide. This gives you an example of, you've got those concentric circles of sort of our leadership group, but this sort of touches on potentially what some of the other research areas, just with the immediate data we have right now, some of the areas we've been looking at. I've started out by looking at, with folks here around MCH. Mike Morris and I are hoping to use some of these finance data to look at that other study I mentioned. And then these other circles with the dotted lines are more things we could and are interested in looking at and having some initial discussions with people, but we're always way open to people who have interest in heading up a study through and with FAST. Next slide, Glenn. So translation, in terms of the translational piece, we're really finding that there's a lot of two-way, this is really truly two-way research. This wouldn't happen without this practice and research interaction. And these PBRN members really know what these data say, how to get them, where to help in terms of have questions related to data, et cetera. Many people have been surprised by the amount of data accessible in their own state that hasn't been used for research but could be and is pretty interesting. I've experienced that myself here in Washington, and there's a lot of interest around this. Next slide, Glenn. This slide is just there to give you, remind me to talk briefly about another part of the translational piece that we're building in. As we have displayed some of these data geographically, when we show them, it generates a lot of interest among our practice partners. And when I talk through some of these data and display it in this way with my Washington colleagues, that's Washington there, our beautiful evergreen state, or ever orange and red and whatever. But
with raindrops.
With raindrops, yeah, small and large raindrops. They just bombard me with all kinds of really interesting points around what's happening in this county, why this county is like that, or that these data are wrong because it shouldn't be like this. Maybe there's a problem there. They have a tremendous amount of investment and information in interpreting what's happening and in data quality, et cetera. So for our purposes, we're right now sort of working on building in a system where we can capture that information and be true to that information flow from practice and interaction around these data. So we then build in a process for improving, being responsive to the data quality issues that they bring to the floor, and weaving in the interpretations that we hadn't thought of, and being, this back and forth, and that's been really a fun experience. So last slide, Glenn. Now I want to, unless people have further questions or whatever, I want to throw this out back to the group, and Glenn, you can add things to or help me facilitate this in terms of, that's FAST in a nutshell, and as we've kind of developed this brief overview to give with more of a focus towards this upcoming grant proposal, and let us know, let's talk about people's ideas or opportunities or next steps or what have you in relationship to this. So I want to open it up. Glenn, you have anything to add or ask or what have you?
Yeah, why don't we start by taking some questions that folks have about the material that Betty has presented around kind of where FAST is now, data wise or with respect to kind of research and analyses that are either underway or teed up for moving forward with the data in hand now. Let's take questions on that first, and then maybe we can move into a discussion about going forward from here. How might we use this new research opportunity to build on what FAST has done and to get some new data into play in terms of research across networks. So first, any questions for Betty? And let me ask, I've got everybody on mute right now to cut down the background noise. Can folks use, if you're able to see your little participant panel on the side, if you can raise your hands. If you click on a little icon that has a hand on it, you can raise your hand and we can call on you. That might be a little easier because we've got a large number of folks on the call, and just to manage questions rather than have everybody kind of blurt out, I thought it might be easier if folks can hit their little hand raise button, and then we can call on you and open up your line to answer questions. I see that Dr. Harmon has raised his hand, so oh, this is going to be tricky now. I got to figure out which phone line is Dr. Harmon. Well, but he's also dialed on the phone. Let me open up these phone lines quickly, and we'll be able to hear from Dr. Harmon in just a moment as I get them opened up. And others, as you're formulating questions, go ahead and raise your hand if you've got a question too, and we can call on you next. Okay, Dr. Harmon,
Yes, can you hear me?
We sure can.
Okay, this is Bob Harmon with the PBRN in Florida. I'm in Jacksonville. Are you getting most of your data directly from local health departments or from state health departments as reported by local health departments?
The latter. The latter.
Okay. So you're getting some of the usual reporting streams on service volume and finance and so forth that go typically to state health departments, and then you're putting it in your database. Is that correct?
Yes, yes.
Okay.
We're particularly trying to stay away from, you know, us or our PBRN colleagues having to, you know, shake the trees among all the individual local health departments.
Okay, so are you getting your data for all the local health departments in the state or just some?
Ideally, all the local health departments. Occasionally there's missing data, et cetera, or,
Sure.
you know, often, of course, the health department is going to have zero amount of service or expenditures in the area because they don't do that service. So, but yes, we're looking for data from all the local health departments, and that's really what we want.
Okay, well that's good because that takes advantage of existing data streams and gives you comprehensive data from each state. In Florida, we're one of maybe 10 states where the local health departments are part of the state health department. We're state employees, and we have uniform data reporting systems, so that's a good way to go.
We've gotten great data from Florida, and but of course it's still interesting when a health department has a zero to report that not doing a service. That's information. That's data too.
Right. Well, it's not required they do all services, of course, and it's all changing with the bad economy.
Right.
Great question. Other questions that people have? Could you raise your little hand and we'll call on you. Okay, Susan from the great state of Wisconsin.
Hello. I was curious on your slides where you said that more WIC services were provided than would be expected according to need. Could you explain what you mean by need and how you measured need, and if that is the same in every state?
Yeah, I mean, we could do a presentation just on that, but in that case, we looked at our quote need, and I think I had it in quotes there, yeah. We really looked at percent Medicaid births or number of Medicaid births in a county. And we looked at, you know, recognizing, of course, that WIC, not everybody on WIC is on Medicaid. So it's not a one-to-one, but we used it more as sort of a ratio. Would we expect for people to be eligible for WIC in a jurisdiction if also Medicaid births were going up? And as a need variable, it did sort of work as expected, and it worked very, very nicely statistically with what we would expect. So that's sort of what we were using as a background predictor of need. That health departments were, and of course that factor was going up and up over these last several years. And WIC service provided by health departments tended to go up even faster. There's lots of reasons why that could be the case. Eligibility requirement changes, et cetera.
Thank you, Betty.
Other questions for Betty on FAST and where things are? We got a question from Barbara. Go right ahead.
Yes, I was curious to learn more about the WIC analysis. First of all, was it in Washington? Was Washington one of the states that where you did that, and where could we find out more about your analysis?
We are something out in MMWR right now. The states that were involved were Washington, Colorado, and Florida. Barbara, remind me, are you one of those states?
Yes, well, yes, I'm working with Seattle King County Health Department, so yes, we're really interested in what happened in Washington.
Yeah, we've got emails out to specifically, we want to specifically have, do a more detailed presentation and discussion specifically with our PBRN partners in those 3 states so that they get their level of detail. And, you know, folks might want to do more with that, run, you know, in state, or the combination of us might want to do more with that.
Yeah, yeah, great, thank you.
Sure.
Okay, next question from Pat. Pat, you have the floor.
Yeah, I'm also from Wisconsin. I'm interested in how you are dealing with your completeness of data issue when you encounter incompleteness, because that has been such an issue in our state in the timeliness of data reporting, either a single, you know, 1 or 2 counties not reporting, or particular pieces of data that would be missing, not 0. And if you're doing any kind of, what do you do when you are encountering that? Are you doing any kind of estimates for those, or leaving those counties out? And then how do you deal with the state if you leave out an entire county? Thank you.
That's, it's an excellent question, and the person who will give you the best answer is not here. That would be one of the folks with the Center for Study in Demography and Ecology. That's where we get our statistical support. So I honestly don't know. In some cases, you can use an estimate based on the trend if you have data for that area for other years. You can do some work. We did do some statistical imputation for missing Medicaid births in Colorado, I remember, for the WIC study. But in general, at my level, I try very hard to get the definitive answer to missing data. But yes, good question. I wish I had a better answer for you.
Well, and it helps if we have annual data over a series of years, et cetera. If there is, in fact, missing data, we can do imputations, and that's filled in blanks. But ideally, we do the legwork first.
Right.
You know, is this a 0, or is there missing data, and what do we, how do we get around that? Yeah. So there are times when we do analyses and just have to leave out some counties for those analyses because we just don't know.
And they sometimes become footnotes in the analysis.
Right. But we've done some imputations that have been successful in acting as we would expect them to do and filling in some blanks. That help?
Thank you.
Very good. I don't see let's see. I don't see any more hands raised. Let me just open up. Anyone else that has a question for Betty that hasn't had a chance to speak yet? Oh, Laura, do you have your hand up?
Yes. Hi, Betty. This is Laura Hitchcock from Washington. I was actually just curious if you could talk a little bit more about some of the national data. I can't remember what slide it was, but where you have the sort of relationship between the various data sets, one of the earlier slides. And you had mentioned, I think it's slide 10, you had mentioned, I think you have NACCHO data incorporated as well, but I just wanted to hear what some of the other national data sets were.
Well, we use, I'd forget, do you have, you know, depending on the issue we're looking at, like right now we're looking at these M.P.H, spending quite a bit of time with M.P.H, and so looking at factors that are known to impact or to be associated with M.P.H-related outcomes. So from the American Community Survey, which gives us more frequent county-level data, census, of course, we've been drawing a lot of data from there, like around poverty and percent of different racial and ethnic groups, around education in community, median income, blah, blah, blah. So some of those that look at county level factors. And I might add, too, we've given a lot of thought to what kind of data to use, too, and made the decision to use a lot from the American Community Survey, in part to be able to get numbers. I won't go into it here necessarily, but we really want to make sure we have numbers of data at the local, in rural areas and not just urban areas. So we can include all counties in our database. Some of this type of work tends to look more at urban areas where you have more data, but we want to make sure we include rural areas. Let's see. Actually, the health outcome piece, we haven't pulled those data in yet. Those are going to be from the vital records, vital statistics. Some of the more really recent years, we will have to get those from the individual states, but we're looking for those to pull them in. The need, again, as we mentioned, was that number and percent Medicaid births in a county.
Right.
So does that help?
Yep, thanks.
Okay.
And we've got a question from Polly as well.
Yeah, I just, when maybe you said this, but one of the problems we struggle with in New Jersey is definitions. So, for example, you said you're counting cases that had an investigation. So you leave that up to the local health officer or epidemiologist to tell you what they mean by that? You know, there's some investigations are pretty cursory and some
Right. Right. No, that's a great question, and this is where, you know, Greg talked about our data dictionary, where a lot of these data don't have you know, we can ask them for, can you send us your data dictionary, you know, and half the time they're going to laugh at us if we ask that.
Right.
So sometimes they've got that, and sometimes they have something like it, and sometimes it's individual people who know the data well, who are explaining to us exactly how they understand people to be defining these cases and reporting these things. But you know, we all know that can get kind of squishy, right? And interpreted a little differently sometimes. So that's going to be ultimately a limitation of some of these data, and we will have to be doing the best we can to see, you know, where, as Greg described, when things don't seem to be acting, when a county's data don't seem to be acting as expected, did they interpret something differently? And sometimes we do some investigation about that. But ultimately, I think it's a limitation of the data. It's also part of getting a part of this whole effort, I think, will hopefully improve data quality. Some people have said that just the mere notion of asking for and using these data in these ways has raised awareness around data quality, and people have started to ask questions about that, as well as this whole notion of collecting some data prospectively, and thereby, you know, improving our data quality and make it more comparable. So, you know, it's a good question. It's something we struggle with all the time.
And can I just add one thing? What I presented, that we have, the data that we have for environmental health is taking what they say at face value.
Right.
When we get to the point where we are actually doing an analysis and we're wanting to use that data, then we will go and start to ask more questions. That sort of thing we already did. as the process of doing the WIC analysis, we learn more and more and more, and we find out, the more you look at the data, the more questions you start to have about these things. So we will develop, hopefully, categories and real precise definitions. What does an investigation actually mean as we get closer to the data analysis.
Great ideas. Thanks.
Fantastic. Well, very, very good questions. I know we've got just a few minutes left on the call, and I'm not seeing. I think we've gotten to everybody's questions. I'm not seeing any new hands up. We might take these last few minutes to talk a little bit about how this new research opportunity for multi-network research that's available from the Foundation, specifically around measuring public health practice and across multiple public health settings and multiple PBRNs might fit into the work of FAST. And certainly, as we talked about on the conference call last week about this research opportunity, we see it as very, very synergistic with FAST, and we want to position it and really use it in a way to advance the goals of FAST to help us collect some new and different data that can help us round out our understanding of practice variation in public health, and hopefully position it so that we're positioning this new opportunity to measure some domains of practice that aren't currently being covered by FAST, and domains where we don't currently have a lot of existing retrospective data that can be populated, because this again, the new opportunity allows us to pass through some research, some resources to each of the participating networks to support some primary data collection or some prospective data collection that hopefully could capture measures that perhaps don't currently exist, but that could really help us flesh out and populate the FAST data, the FAST research effort with some new and better data. So certainly, as we talked about on the conference call related to the new funding, once the participating networks have been selected, we'll spend the initial months of the grant period looking at identifying possible measures that can be selected. We certainly will not want to duplicate the data and measures that have already been captured in FAST. We'll want to look at again at opportunities for measuring additional elements of public health practice, and again specifically measures that we can collect validly and reliably, on a prospective basis. So moving forward over the 18-month period of the new funding opportunity, using those resources to collect, additional data on public health practice at the local public health practice setting level. As Betty mentioned, this new RFP funding opportunity from the Foundation has identified 3 kind of priority domains for measurement, 2 of which are in common with the FAST study, and those are chronic disease prevention and control and environmental health. The third priority domain for the RFP is chronic prevention, and that's an area that's an entire domain that currently is not covered in the FAST. So obviously that is an opportunity for us to use this new opportunity, populates and collects some measures on what public health agencies are doing around the country with regard to chronic disease prevention, and measure and compare those activities across PBRN networks. So that's kind of at a broad level how we're thinking about positioning this new opportunity to be very supportive and synergistic with the work of FAST, and really to help advance the overall goals of FAST with some resources for new data collection, as well as for additional data analysis through this activity. We can certainly take some we maybe have time for a few questions on that as we're closing out. And I'd say, Betty, if you have some additional thoughts as well, you want to chime in around this new opportunity as it relates to FAST, please go right ahead.
And Glenn, we'd be thinking that those data, for example, would be added to this database, be part of this larger relational database. So to add to the along with these other measures, et cetera. So it could be seen as being able to utilize some of this other what's already there or will be added to it.
Absolutely. The data that will be collected through this new RFP Opportunity Foundation, we will use that to further populate the shared data resource that's being constructed through FAST. And so, absolutely, these data that we'll collect through this new opportunity will add to the data infrastructure that is a part of FAST and that's available to PBRN networks for research.
Right.
So not hearing any other questions, and we are at our time. We're closing in on at 4:30 now. So so to be respectful of everyone's time, why don't we go ahead and close out for today? We have recorded this session, and we'll make that available on the website for those people who you might know in your network who would be interested in this, who couldn't be on the call today. Also, if you've got additional questions or ideas or thoughts about this work, about the FAST work, about the new RFP, please let me invite you to email those to us at publichealthpbrn@uky.edu, our new PBRN email. We'd love to receive those. We'll be glad to respond to them if you have questions that need answering. And we'll also relay these questions to Betty and her group as well, the questions that have implications around the FAST work. We'd love to do that. So please, please, as you've got ideas and thoughts, send those to us via email. We'll be glad to facilitate kind of an ongoing conversation about the work of FAST and about this new research opportunity that way through the web and through our email exchanges. We'll also have a chance, don't forget, tomorrow is our monthly PBRN conference call, so we'll have a chance to touch base as well on these issues tomorrow at our regularly scheduled time. I think it's 1 o'clock Eastern, 1 to 2:30 Eastern. And so please, we'll look forward to continuing the conversation there as well. Thank you so much to Betty and the rest of the Washington PBRN and University of Washington FAST crowd for hosting this conversation today. Thank you all for participating, and we'll look forward to continued dialogue and collaboration on these efforts.
Great. Thanks, Glenn.
Thanks so much.
Thank you.